Good afternoon, everyone. It's good to see everyone here today. We are honored to have Dr. Dean with us. Thank you for being with us for our Diversity Speaks, Power, Privilege, and Public Health, how public health policies, oh goodness, just it's okay, there you go, get used from harm and how to address it. Sometimes, our little screens get cut off and so got cut off. But it's so good to see everyone here today. I'm going to speak a little bit about Dr. Dean because her bio is just amazing. So we are really privileged to have her with us today. Dr. Dean is Associate Professor in Epidemiology at Johns Hopkins School of Public Health. As a social epidemiologist, her work privilege and health, including social and racism discrimination, social capital, the screen, economic, consumer credit, social economic position, detriments of disparities in cancer and HIV. She's a co-author of the recently released book, Power, Privilege, and Public Health Theory and Practice. She has led several studies as PI of NIH, the Robert Woodson Johnson Foundation Center for AIDS, research and institutional grants. She holds a doctorate from Harvard School of Public Health and was a J. William Fulbright awardee to Venezuela. So please give a great Diversity Speaks welcome, PHRC Speaks welcome of having Dr. Dean speak with us today. Dr. Dean, thank you so much for being with us this afternoon.
Thanks for having me. A 2025 Gallup poll in the US found that while Americans see healthcare providers, people like doctors, nurses, scientific researchers, and even the Centers for Disease Control as part of their most trusted sources of public health information, only 3% ranked political leaders as trusted sources. Maybe they're onto something. Although health and the public health fields are supposed to be helping fields, that's why we get into them, there are many examples when public health policies that political leaders have activated have been used for harm. And that's what we're going to talk about today. I'm Lori Dean. I'm Associate Professor of Epidemiology and Oncology at Johns Hopkins Bloomberg School of Public Health. And I'm here to share with you about how this has happened in US history, both some historical examples as well as some more recent examples. And this is based on my work as co-author of a book called Power, Privilege, and Public Health. It's newly released. And we're going to talk about one of the chapters of the book that focuses on how public health policies actually get used for harm, sometimes intentionally and sometimes unintentionally, and then some thoughts on how to address it. I'd like to thank you all for being here today, and I'd like to thank Director Harris for inviting me, as well as the many other people involved in helping to set up today's presentation, Anita and others. Thank you. So as I mentioned, there is a text that's newly available called Power, Privilege, and Public Health in the US. It'll talk a little bit about defining power and privilege, other topics like intersectionality and health equity frameworks. But today we're going to talk about just one chapter of this book that essentially focuses on thinking about what examples do we see so that we can avoid future times that we might see how public health policies have been weaponized against people or actually have been used to harm people. When I say the words power and privilege, I'm talking about two distinct concepts. When I say power, I mean things like the ability to influence, define, direct, and determine people's behavior. And that's generally patterned by the amount of resources that someone has. But there's also different types of power. There's power over other people, there's power to do something, there's power with other people, like social capital that might bring people together. And there's also power within, things that you can do within yourself. So when I talk about power, I'm not just talking about one dimension of power over people. There are many ways in which we can both use power in some cases to create these policies, but then also to dismantle the harms that some of these policies have done. When I say the word privilege, I'm talking about something very specific as well. And I know the word privilege has been thrown around a lot. You've probably heard it a lot recently. But in this case, I'm specifically referring to unearned, and I want to emphasize unearned rights, benefits, immunity, and favors that are bestowed upon individuals and groups, so it's not just individuals, on the basis of things like their race, their culture, their religion, gender, sexual orientation, physical ability, or other key characteristics. So this is not a full list. But when we think about privilege, I think I want you to really consider that this is about unearned rights or advantages that people have, both as individuals and as groups. And in the book, we talk about privileges being an umbrella. And we talk about under that umbrella, there being essentially three distinct flavors or categories of privilege. So one might be economic privilege. And if you think about things like generational wealth, that's unearned wealth, or legacy benefits that allow people to get into schools that they otherwise wouldn't get into simply based on having a generational experience at that school, or educational elitism, right? Those things might be economic privilege. We also can talk about social privilege. So when we talk about racial hierarchies or sexuality and gender or immigration status, those are things that might fall under the umbrella of social privileges. And then there's somatic privilege. Somatic privilege is thinking about physical ability or neurotypicality versus neurodiversity. So these are the overarching branches that we talk about when we talk about privilege. But I want you to think maybe differently than you've thought about privilege in the past. Because a lot of times people will talk about privilege as if it's only about individual characteristics. But I want to challenge that a little bit today. And I think that the sharing might have changed. Did the sharing change? Can you still see my screen?
Yes, we can see your screen. That was launched accidentally. We're good.
Oh, just make sure. Okay, you should still be able
You
to see
should be
my.
good. Mm-hmm.
So I want to challenge you in thinking about privilege from an individual perspective. Instead, think about privilege as a system. And there's a author named Stephanie Nixon who has written about privilege as a system, and she talks about privilege as a two-sided coin. A coin, the coin of privilege, she calls it. And she talks about privilege being this coin, where you often think about some people at the top of the coin as being privileged, and then people at the bottom of the coin as being those who are oppressed. The challenge here is that it forces, and thinking about that, forces you to think about privilege as a binary. But the challenge with that is there might be some ways in which sometimes you might have a characteristic that lands you at the top of the coin, and other times you have characteristics that land you at the bottom of the coin. So both privilege and oppression can exist even within the same person at the same time. And instead of thinking about privilege as something as part of individual characteristics, we really need to think about the coin itself. And the coin itself represents different systems of inequality that we need to then dismantle in order to essentially erase this concept of privilege and oppression. So, Stephanie Nixon suggests that we need to look at the coin itself, the social structures that produce and maintain inequality in our society. And these are things that can be embedded in our public health laws and policies. But importantly, it takes the emphasis off of these individual characteristics, like being male or being cis or being disabled or Native American or straight or trans. It takes the emphasis off of individual characteristics and shifts us to thinking about populations and systems, which is what we need to address. So today we're going to talk about some of the examples of ways in which these structures of power and privilege that you saw in that coin end up being used in public health policies. And I'll talk about this across three different themes. One is, for example, you would often hear about public health being done in the name of scientific progress. You might also hear about public health policies or public health being done in the name of protection. And sometimes we do public health in the name of preserving the status quo. But I'd also like you to think about the ways in which, and public health is an easy Trojan horse because public health is something that a lot of people can get behind, right? Most people would agree that we want to improve the public's health. But sometimes when people are using these themes, we're doing health in the name of scientific progress or protection or preserving the status quo, it's actually coding for something else that's happening. And again, sometimes those harms are unintentional, but sometimes they are intentional. And we'll talk about examples of both in the upcoming slides. So in that first theme, when we think about public health research in the name of scientific progress, A lot of times, what we see is research done for progress, but not necessarily for people. And I think the question here is to think about progress at whose expense. And I'll share some historical and contemporary examples in the United States. But first, let's travel to 1971. In 1971, there was a faculty member at the University of Minnesota named Dr. Louis Wanamaker, who led a series of studies focused on the use of penicillin to treat impetigo skin conditions. Now, at the time, there was already a strong body of research suggesting that penicillin was effective at stopping strep infections in military personnel. However, the researchers at the time argued that there was limited evidence for how penicillin might work in what they called populations at high risk. And one of the populations at high risk they identified was a Native American population called the Red Lake Nation, or indigenous population called the Red Lake Nation. So, in the name of advancing science that they said themselves would benefit military personnel, not just anyone with these strep related impetigo conditions, these researchers used children at the Red Lake Nation as a testing lab. This work was funded by the US military. So, as I mentioned before, these are state sanctioned activities. And in these experiments, they took 78 children from 18 families and enrolled them and followed them to assess how penicillin, and particularly different doses of penicillin, might prevent these new impetigo skin lesions, and then followed them over a 6-week period. So, on the surface, that might not seem that harmful, right? I mean, weren't they doing this work to improve the lives and the health of these children? Well, the overarching problem was actually their goal. Their focus was on identifying and studying a health problem without a commitment to actually healing the problem in the community. They were only using the children as a testing lab, as I said before, because they were interested in how this might affect military personnel, but expressed no further commitment in actually resolving the challenges, these strep related infections that they were seeing at the Red Lake Nations. And in fact, this was called out by the Truth Project in 2023. And one group actually stepped up to say that their intentions were to stop that racist research by working with the Indian community and to work with them to eliminate the impetigo problems from the children. A very different emphasis than actually just doing this research for the sake of understanding what should happen with military personnel. But they went so far as to say that it illustrated the institutionalism of the racism, because when a volunteer organization has to eliminate a problem that a professional team of investigators has been paid $500,000 to study, something is wrong, both with the research itself, the granting institutions, or the healthcare institutions. So the overarching problem, again, was that they were focused on identifying and studying a health problem without a commitment to healing the problem in the community, and then leaving it to an external organization who was less resourced to actually resolve the problem in the community. Again, they were doing research for scientific progress, but not based on actually healing the problem in the community that was being presented. Another example closer to home. I know you're in Pennsylvania already, but Holmesburg Prison near Philadelphia. This was the site of, I would say, atrocious unethical experimentation on 300 mostly Black male inmates over a period of about 23 years. And you can see something that's shown depicted in this picture here. So between the 1950s and 1970s, a man named Dr. Albert Klingman, who was a faculty member at the University of Pennsylvania Department of Dermatology, that's actually University of Pennsylvania is actually where I did my undergrad, so it's actually my alma mater. They were called to the prison. He was called to the prison initially just to treat an outbreak of athlete's foot. But up through the 1970s, he actually continued to work with these prisoners and subjected them to testing of chemicals and medications from all types of other things. So essentially used them as a testing lab for cosmetic and pharmaceutical companies. So testing viruses, fungi, asbestos, and chemical agents, and exposed these men to all different types of things, including poisonous skin blistering chemicals, things that were used, for example, the active ingredient in Agent Orange, radioactive isotopes. He even went so far as to remove their thumbnails to infect them with ringworm to see what happened. He actually described these inmates as, quote, natural sources of scientific advancement. So again, here we see the language of scientific progress being used at the expense of these inmates and people and doing this experimentation on these inmates. Now, some people would say, well, the inmates did agree to it, and they did. Participants were consented and paid, but the process of recruiting them was essentially coercive. Most of them didn't have access to literacy, so it's not clear whether or not they actually understood the full risks. And the risks were really not explained to them in a way that informed consent could actually be obtained. So most of the incarcerated people were also still awaiting trial. So the prison was playing on their poverty and their desperation for things like bail money, and then paying them, for example, $1 per day to get them to agree to these abusive and atrocious experiments. Meanwhile, at the same time, Dr. Klingman was receiving all types of academic awards, publications in prestigious journals, and even financial incentives from places like Johnson and Johnson, Dow Chemicals, and the US Army, while exploiting these inmates. The sadder part is that the victims of these experiments had long term health risks and challenges, which they do believe originated from those experiments. And in fact, in 2000, a group of the victims called the experimentation survivors used it as a foundation for a lawsuit against Klingman and University of Pennsylvania. They were trying to receive some sort of financial remuneration and access to medical care based on the experiments that they had been subjected to. But even then, they still didn't find justice or redress. And it all came down to a 2-year statute of limitations, which would have actually required them to file a lawsuit while they were still in prison. So absolutely nonsensical. But their current lawsuit, the lawsuit in 2000, was thrown out because those experiments had been done in the 1950s and 1970s. And under that 2-year statute of limitation, they would have been expected to supply to file that lawsuit while they were still in prison. Instead, what happened was the mayor of Philadelphia issued a formal statement of apology. That was happened in 2022, so just a few years ago. Penn removed Klingman's name from different honorific events, and the university set aside funds for fellows to study dermatological issues in Black and other people of color. For me, it's kind of interesting that despite the fact that the university had originally sponsored this harm, they then later, after recognizing and acknowledging this harm, then went back and funded themselves to do more work in this population. I found that really interesting, and actually even more kind of almost doubling down on the challenge and the problem that we see here. All that to say, in looking at these examples, we have to think about when people say we need to do something in the name of scientific progress, what that really means. And as quoted in the book, we must reject the notion that scientific progress can occur without attention to equity, and only accept progress or only accept that something is progress when the benefits of health and medical science are equitably applied. It's not acceptable, and it's not required that the health and well being of some people are sacrificed to preserve the health and well being of others. So, I offered you these two examples of scientific progress and the ways in which people have used the theme or excuse of scientific progress, but in essence, used it in a way that ended up harmful to a population. At the end of today's talk, one of the things I'll ask you to reflect on is whether or not you're still hearing this today, and some examples that you might be hearing in new scientific progress, and whether or not we are thinking about them in the way of equity. But what I'd also say is when you hear people talk about needing to do something in the name of scientific progress, challenge who benefits in this progress and who might be harmed, and make sure that people aren't left behind in that progress. Another theme you might hear is that we need to do this in the name of public health protection, right? That's hard to argue with protecting people. But I'd also say that that same argument has been used in cases when the healthcare system should be stepping in and protecting people. And instead, we criminalize people who are in need of health care. One of the clearest examples of this that I can show is in the reactions and the different ways addiction to powder cocaine versus crack cocaine has been treated by politics and the media over the course of the last 30 or so years. So in the 1986, there was a lot of rhetoric by then President Reagan talking about the rising rates of use of crack and cocaine. In the speeches of President Reagan, they talked about things like crack and cocaine being addictive upon first time use, and most folks focus mostly on the crack version of cocaine, not the powdered version of cocaine. They talked about mothers' usage leading to crack babies. And so they framed this about the health of children, again, protecting children. And who can really argue with protecting children? And in fact, you might even remember, if you're old enough to remember, Nancy Reagan's campaign on the Say No to Drugs campaign, or the This is your brain on drugs campaign. Many of us have seen these examples. So, in response to all of this rhetoric about what they were talking about, these rising rates of crack and cocaine, they decided to introduce this Anti Drug Use Act, and 2 years later, another Anti Drug Use Act that essentially established mandatory incarceration sentencing for people distributing different quantities of cocaine. But this was also very racialized. Some of the things that they had seen was that crack cocaine was cheaper and more accessible to people with low incomes who happened to disproportionately be Black or people of color, while powder cocaine was more expensive and more prevalently used by affluent white people. However, when they actually did this mandatory incarceration sentencing, they treated crack and powder cocaine differently. It took distribution of only 5 grams of crack cocaine to earn someone 5 years in federal prison. However, it took distribution of 500 grams of powder cocaine to land someone 5 years in prison. So, in essence, it took 100 times the amount of cocaine to trigger a 5 year sentence in prison when comparing powder cocaine versus crack cocaine. This became known as the 100-to-1 ratio because it took 100 times much distribution of powder cocaine than crack cocaine to get that same prison sentence. So this was also, you can also see the racialized depictions of this in the media. And in fact, President Ronald Reagan talked about this in framing of public health. He said, today there's a new epidemic. This was in his address in 1986. He said, smokable cocaine, otherwise known as crack, it's an explosively destructive and often legal substance, which is crushing its users. It's an uncontrolled fire. Now, I'll ask you to notice the language that he used here. He used the word epidemic. It's explicitly the language of health, but the solution was never a health solution. Both the sentencing ratio that you saw and the images contributed to drug use being assigned a moral and individual failure rather than the medical issue that they were essentially even framing that it was. And instead of actually offering health resources to people, they decided to criminalize these behaviors. And in fact, the mayor of New York, a couple of years later, and this was a Democratic mayor of New York said those people, referring to people, for example, who were distributing cocaine, belong in jail. Those people belong in jail. Those people who are users, I have no sympathy for them, none at all. Maybe in the past we did. It has gone on too long. So again, even though they're explicitly using the language of health, they're talking about how this health issue then needs to be criminalized. And the result that this had was that Black drug users ended up being sentenced to federal prison rather than being offered health care for their addiction, which resulted in disproportionate incarceration rates for Black people. And there's a tail on this because, in fact, the Anti-Drug Abuse Act of 1986 contributed to the quadrupling of the prison population between 1980 and 2000, 2/3 of which were charged with drug possession. And despite the Black and white people have similar rates of drug use, Black people were still 3 times more likely to be incarcerated for drug possession. That same year that the mayor of New York talked about cocaine and talked about the distribution of cocaine, the crack cocaine, as being something that needed to be criminalized, as something that needed to be put in, people that needed to be put in jail. That same year, there was actually an article in the New York Times that further reinforced the differences in even distinguishing crack from powder cocaine. Differently, they actually called powder cocaine a rite of passage that should not be criminalized And in this article, they talked about alleged differences in addictive properties. And you can see at the end of this article, it says, more importantly, the potent smokable cocaine derivative called crack appeared in quantity on city streets in late 1985. The speed talked about the speed of addiction, weeks instead of years, and the way treatment centers in New York were set up, and all of those things. So they're invoking all of this rhetoric to talk more about how crack cocaine was so much worse than powder cocaine. and use these as arguments to essentially get the media and to get the public on the side of supporting these policies, like this 100-to-1 sentencing ratio. So, okay, was there any actual truth to this sentencing ratio? I mean, maybe there is some truth to what these folks are saying. Maybe there is good reason to have this sentencing ratio. Well, let's look at some of the facts. And I'm going to ask Anita to pull up the poll because I'm a professor. So you're going to have a quiz on crack versus cocaine and what you know about crack and cocaine. And we'll see whether or not some of these things that have been said about crack or cocaine are true and whether or not these changes are warranted. So we're going to launch a poll that should show up on your screen. You should get 4 questions. I don't think the poll is showing up for us yet. And then I'll give you a minute to go through the 4 questions and then we'll talk about your answers.
I'll see the polls yet? No,
Not yet.
not yet. Okay. Let's see. Okay. For some reason doesn't seem to be launching.
Oh, we had tested
And
it
you,
earlier and it was working great.
yeah, you know what? I think it might have already launched in the chat, to be honest with you. If you all, can we all look in the chat and see? Can you all look in the chats?
Yes, if you would
Mm-hmm.
just please scroll up. The questions are.
Okay.
Yes, because I think we launched them already. They're in the chat. All 4 of the questions, Dr. Dean, would be in the chat.
Okay.
They're there. And I
There's
can
someone they can't
also,
click on the answers.
yeah. If
Someone says
you
people can
click
see
on
them, but
true
they
or
can't
false,
respond.
here, let me post it again. It's also in the chat. You see it now? Click on true and false and click on submit. And it's also in the chat.
Yeah, they don't fully work for me.
Hmm.
Oh,
Can you all
someone said,
mhm. You all put in the chat if it's working out for you all in the chat section?
interesting. It's working for some folks, but not for others.
If you click the poll icon at the top of the screen, you may be able to pull it up and then submit.
Okay. Thank you, Katie Martin. Submit for mine. People are seeing my questions. Mhm.
Okay, looks like we have some responses to questions. Like people are still answering. I'll give you just a couple of more seconds to answer.
Is that helping a bit?
Okay. Looks like it's working for more folks.
Good.
Maybe about 30 more seconds, 15 more seconds.
Seeing more responses coming in now.
Mhm.
More responses are coming in now. That's good here. Okay, I'm gonna stop sharing here.
Okay. How are we looking? So hopefully people who've been able to, it seems like some people have been able to vote. If you haven't been able to vote, it's fine. You can silently answer these questions and hopefully see these questions. All right. So let's see what the reality is here. And I'm going to go ahead and reshare my screen. All right. So Is this valid? Is this 101 sentencing ratio valid? Well, let's just start with some facts about crack and cocaine. So the first one is both crack and cocaine are made from dried coca leaves. Seems like 75% said true, 25% said false. This answer is true. They're both made from dried coca leaves, so they both have the same underlying chemical composition. How about this next one? Using crack cocaine while pregnant leads to crack babies, children born with lasting mental or physical damage. And this is something that we heard a lot during the Reagan administration. With the Reagan administration, he actually never used the word crack babies, but this was something that the media kind of glommed onto as he was talking about the protection of children. So 66%, most people said that this was true, and only about the third of people said that this was false. This is actually false. And in fact, this was something that was completely unfounded. While prenatal crack use can cause premature birth and low birth weight, those born at full term show no significant long-term developmental differences from children raised in similar socioeconomic environments. In fact, what they actually saw, what they were attributing to what they saw as crack babies, was due to the detrimental effects of things like poverty and low resources, lack of prenatal care, alcohol and tobacco exposure. Those far outweighed the effects of prenatal cocaine exposure. So no, so this is actually not true. While there are some elements, for example, of they don't even necessarily even call it addiction, that they don't even talk about addiction when it comes to babies or children when babies are born. But essentially, there's no lasting mental or physical damage that happens if a mother uses. Now, that doesn't say parents should use drugs. I'm absolutely saying parents should not use drugs, the birthing parent should not use drugs or alcohol. But in terms of the rhetoric at the time, this was actually completely false. And there's been tons of science to disprove this. Crack cocaine is more dangerous or more addictive than powder cocaine. That was something that even Reagan talked about in that speech. So most people said that this was false, and indeed it is false. And in fact, the difference is really due to the way that the drug is taken, being smoked or injected versus snorted, but not due to the chemical composition of the different forms of cocaine. Again, they're both same from the dried coca leaves. So this is really about the mode of administration, not necessarily about crack or powder cocaine. So again, another unsubstantiated and unfounded claim that they were using at the time to support these differences in sentencing. And then the final one is racially minoritized people are more likely to use crack than powder cocaine. 75% of people said that this was true, whilst 25% said this was false. And this is technically false. And this one is a little bit tricky, and it can feel misleading, because the reality is crack is actually more likely to be used in individuals of lower socioeconomic classes, despite their ethnic background. And at the same time, people who are most likely to be in a low socioeconomic background, they're disproportionately people who are racially minoritized. But if you actually look within, for example, racial groups, it's really people who are low income. They're overwhelmingly more likely to use crack than cocaine. It's driven largely by income rather than race. So even the rhetoric of them using these racial arguments was unfounded. They could have used that argument around low income, and then that would have kind of captured people across races in terms of capturing who really needs to be treated and who needs help here. But they didn't. Instead, they made it about race when it was really about income. So all that to say, recognizing that how many and how much of this rhetoric was false, the impact of this law was finally addressed over 20 years later under former President Barack Obama's 2010 Fair Sentencing Act. And that was originally written to completely eliminate that 100-to-1 disparity in federal sentencing of crack and cocaine possession. So when it as written, it was supposed to completely do away with the 100-to-1. However, in a capitulation to the Republican Senate Judiciary Committee members, they actually ended up changing that, and the sentencing ratio was instead reduced from 100-to-1 to 18-to-1. So even today, remnants and legacy of this is still in place. Now, I'd also say this isn't the first time that we've seen this, and maybe not the last time we've seen this. If you think about today's opioid epidemic framing, right, people are now talking about both Democrats and Republicans, for example, have stressed their compassion for heroin and opioid users. They've shared anecdotes of addiction within their own families. So there are ways and contemporary ways in which we can talk about addiction and about drug addiction in ways that are actually framed with public health solutions and not criminal solutions. But you can see that back in these days, back during the times of in the 1980s, especially, this was really being used and weaponized against people of color when it didn't need to be. And there is a legacy in the US of using policies to discriminate quite actively against certain groups of people. And another example in that this is done in the name of public health protection is when these public health policies are specifically weaponized to discriminate and oppress. And this example comes a little bit closer to home to me at Johns Hopkins. So Johns Hopkins is situated in Baltimore, and in the early 1900s, tuberculosis was one of the most deadly communicable diseases in the US. It killed 194 per 100,000 people. And we already also knew that there were these race-based disparities in mortality outcomes. Essentially, that there were different rates, people died at different rates based on their race when it came to tuberculosis or TB. Baltimore decided to tackle this, and in 1904 decided to host a conference where they unveiled some maps of where tuberculosis deaths were happening in Baltimore City. And you can see on this slide the maps shown here. The red dots represented white deaths, and the blue dots represented the deaths of Black people. What it pinpointed and what this map pinpointed was that there was an area around the predominantly Black neighborhood of Druid Hill Park. So if you've heard the group Drew Hill, this is exactly where Drew Hill would have come from later, much later on. But this Black area of Druid Hill Park had troublingly high rates of TB. They were actually 7 times higher than the rest of the city. But when this problem was framed, instead of it being framed as a problem that could be addressed within a particular geographic area, it was framed as troubling because of the threats it posed to Baltimore City's white population. And this was pretty explicit, as we'll see in the upcoming slides. So this particular area, which housed working class Black people, were often domestic workers in white homes. And you can see in the slides the occupations. These are the occupations of most of the Black people at the time, the Black people who had died of TB at the time. And many of them were domestic workers, and white homes are interacting with white workers or customers. So Black people were being framed as vectors of disease to white families. In producing these maps, Baltimore's area that they then called the lung block, because TB is something that would affect your lungs, became a symbol for Black disease. And tuberculosis containment became the way in which public health policies were then weaponized to restrict the movement of Black bodies in the city. So Dr. Lawrence Brown has a book that really highlights this. It's called The Black Butterfly. And he talks about how sanitation, again, public health laws in Baltimore City, were used as a grounds for racial segregation. So in the early 1900s, there is this Black Yale graduate, George McMechen, and you can see him pictured here. He's actually in this article right here. And 3 additional families moved into a previously all-white neighborhood in Baltimore. Now, what happened when they moved in, this prompted fears of what the media would call a Negro invasion, and prompted actually the mayor at the time, John Barry McCool, to sign the nation's first set of anti-Black racial zoning laws, and talking about this in a way that invoked protecting health. So again, there's that argument of protecting health. He actually said Blacks should be quarantined in isolated slums in order to reduce the incidence of civil disturbance, to prevent the spread of communicable disease into nearby white neighborhoods, and to protect property values among the white majority. At no point did he talk about the actual health of the Black populations and the Black people who were disproportionately dying of TB. Now, that happened in 1911. He signed these anti-zoning laws. And a couple of years later, the Supreme Court did overturn those laws, saying that it was unconstitutional. But interestingly enough, when they said it was unconstitutional, they actually didn't say it on the basis of discrimination against Black people. They said it because it restricted white homeowners' choice of whom to sell to. So again, it was still framed as the protection of white wealth and white health. The Baltimore's next mayor, kind of recognizing what happened with this Supreme Court and the overturning, would continue to run on a platform of continuing this crusade and essentially using this tuberculosis as a way to maintain segregation in Baltimore, still continuing to invoke this health argument. He even went so far as to implement a rule requiring city building inspectors and health department investigators, so used public health inspectors, to issue code violations to homeowners who rented or sold to Black homebuyers in white neighborhoods. So again, this is a way in which public health professionals, public health inspectors were being used to enforce racial segregation in Baltimore. And in 1917, he convened a group of physicians, social workers, and other people and other citizens who were finally starting to talk about the death rate of Black Baltimoreans due to TB. So over time, he started reframing the need for these policies, about displacing about now saying, okay, not only is this about protecting the white population, but this is now also about protecting the Black population. But now his argument became, we're still going to use segregation, and what we'd like to do is create a colony outside of the city of Baltimore and move the Black people to that colony. And again, all prior indications of his intent suggested that the real motivation was about in maintaining segregation policies to protect white Baltimoreans. This was really never about Black health. It was just a convenient argument that served the purpose of appeasing white fears of this what's called Negro invasion. And you can see here in the news, in the Baltimore Sun, and other places, that they talk about preventing this Negro invasion. This Negro invasion halted, that the mayor was doing something to fight this Negro invasion. It's interesting to even think about the word invasion, right? It's almost like a war term, as if people are coming to take something away, or some people are coming to harm or hurt, when that wasn't the case. So despite that, Preston and the Baltimore Health Department, they knew at the time that it was really about the unsanitary social conditions that the Black neighborhoods were exposed to, and the derelict conditions of things like the sewers in the alleys in Black neighborhoods that was causing the TB. They still purported that exposure to Black people, not the neighborhoods, was the cause of the spread of TB. And that would warrant some sort of race-based quarantine, and that would be necessary for the protection of white health. So the newspaper continued to advance this. They even talked about Black people as a menace to the health of the white population, in addition to showing how, but I think this also shows that in addition to it not just being about policies in the name of preserving health, the media also gets weaponized in other ways, in other domains of society can also be weaponized to talk about this or to advance these practices. So all that to say, discriminatory intent or impact is sometimes coded as protection against health risks, and that often involves limiting the spread of disease. But over time, we see this for what it is, that proponents of discrimination have then become savvier and at times then reframed their discriminatory actions as a way to then protect the health of oppressed populations. So it's something we do need to be careful about. So in the final set of examples I'll show you is talking about not just policies about who gets access to health, but even health education can be weaponized. And in fact, we'll use the example of the Flexner report and how Black medical schools changed in the United States. And this was something that was done in the name of preserving the status quo. So before 1910, there were 7 Black medical colleges in the United States. And these 7 Black medical colleges were training Black physicians, largely because of that same that we talked before, fears of contagion from Black to white communities. And that's what really drove efforts to train Black physicians. Now, they were doing this in a very limited way. They focused mostly on disease containment and sanitary conditions, rather than actually talking about the health or the overall health of nearly 10 million Black people in society at the time. So yes, there were Black medical colleges, but it wasn't exactly as progressive in the way that we might think. That it was really about training Black physicians to only deal with sanitary conditions and other things, as opposed to, again, just preserving overall health, or training them to treat anyone, not just the Black population. So before 1910, at around 1909, the Carnegie Foundation set a charge that they said was motivated to improve the nation's health by focusing on improving the quality of medical education. At the time, medical education was based on a for-profit model, and they said that it led to a large number of poorly trained physicians. So as a result, they hired this man, Abraham Flexner. Now, Abraham Flexner was an educator. He actually wasn't even a physician. And he surveyed 155 medical schools in the US and Canada to generate a report on the quality of medical schools at the time. Now, I'd also say that looking back, historians now recognize that this study might have actually also been covertly funded by the Association of American Medical Colleges because they had a vested interest in protecting the finances of physicians, and they might have actually wanted to limit the size of the physician workforce. Interestingly enough, we can still see legacies of trying to limit the size of the physician workforce today in our shortages that we see. So Abraham Flexner was commissioned to do this report, and he evaluated medical schools based on the rights and resources those schools had in relation to the overarching universities, their admission standards, their physical facilities, whether or not they had well-equipped laboratories, and the type of instruction that they were getting. And essentially rated medical schools into three different categories, using my school, Hopkins, as the gold standard. So essentially, he said that the best medical schools would require at least a high school degree, 2 years of college level science admission, well equipped laboratories, and have some sort of affiliation between a teaching hospital where the faculty controlled clinical instruction or were involved in clinical work. Then he also categorized people as improvers, some laboratory facilities and clinical access, but didn't have the endowment or a university affiliation that would sustain what he called high-level scientific medical education. And then he talked about these ones called the non-existent, ones that required little or no prior education. They were often for-profit schools. These were owned by groups of local doctors, so they actually called them medical diploma mills that didn't have laboratories and didn't have access to hospital wards. So the Flexner report actually led to the closing of a lot of medical schools, but particularly and was disproportionate in ones that served Black and female medical students, and those were disproportionately affected. In fact, it reduced the number of HBCU or Black medical schools from 7 down to just 2, Howard and Meharry. So, and what was really happening is that at the time, Black medical schools didn't have those same endowments and resources. One, they were trying to keep tuition affordable for Black students. They didn't have the endowments that the white serving medical schools had because they were often funded through church donations or charitable giving. So when the Flexner report was issued, 5 of those 7 Black medical schools were considered substandard and were later recommended for closure, really based on resources, which could have been the recommendation, was that these schools needed to be better funded, not that they needed to be closed. But there's been lasting impacts of that. Some estimates, in fact, suggest that had those 5 medical schools not closed, they may have educated some 30 to 35,000 Black physicians over the past century. And we still really haven't recovered from that. In 1970, the AAMC had set a goal of 12% for Black medical student enrollment. It still hadn't been met 50 years later. And they actually documented that even 100 years after the Flexner report, the proportion of Black physicians to the US population was actually lower than it was in 1910. All that to say, even in 2023, which is the last estimates that I could find, the AAMC still reported that only 6% of physicians were African American, which was only a 5% increase in over 120 years. Now, this was largely driven by an increase in Black female physicians or women physicians, but with no statistically significant change in the percentage of Black male physicians. So the legacy of these policies, even if they happened a while ago, are still in effect and still affecting us today. But this is not just history, right? We still see that these 3 same themes of scientific progress, protection, and preserving the status quo are still used in contemporary examples. So, for example, if you looked at a couple of years ago, the Trump administration using health insurance as a reason to deny visas to people who were immigrants. Now, while this was overturned by the Biden administration, there are still remnants of this, and this still continues to pop up in the current administration of using things like health insurance requirements to restrict who can come into this country and who can stay in this country and who can work in this country. Or if you think about the recent news and the recent talks about banning gender affirming care for young people. If you look at the articles and the arguments for this, many of them talk about this is about protecting young people, right? And that gender affirming care harms young people. But we know that's not true. There's no evidence that it's true. And in fact, gender affirming care actually helps reduce things like self-harm, and helps actually again be more gender affirming in terms of their both physical and mental benefits for young people. But they're still reframing this and still using this argument as if that these bans are going to protect young people, right? Public health protection being used. So I hope in taking this walk through history, it's helped you to reflect on policies that might be unfolding around you, especially in the regulatory space, and how these arguments might be used, sometimes in cases to hurt people intentionally and sometimes to not hurt people intentionally. So all that to say, you have to be careful when you hear things being framed as we need to do this for scientific progress, protection, or preserving the status quo. And you really need to think about who is it benefiting and who is it harming across the board, and refuse to accept if it's not equitably beneficial. So, what are some of the ways that we can do this? One is we need to recognize that privilege is a system, and there are many forms of power to wield this. So, when you recognize that a policy is being unrolled or a public health policy or something is being implemented, think about again who might be at the top and bottom of these coins. Though again, this is not about necessarily a binary, but thinking about how the different systems of inequality might be playing into who is harmed or not harmed from the policy. But then also think about, inspect who is in power that's advancing the policy, who has something to gain from it, and then who might lose from it. And recognize that there are other counterpowers that can be used, power over, within, or to actually address those policies. We also need to recognize that these are systems that are at work. So one of the things we need to do is recognize and start with the assumption that systematic oppression is actually happening. We have to be vigilant and assume that if we don't change our practices and that if we continue to move in the direction that we are moving, that these things will be proliferated. So we have to be intentional about actually stopping systemic oppression from happening in our systems. We need to be sure that we're leveraging our power to dismantle it. And we talked about the power to, within, and power over. And that recognize that these systems are interconnected. So it's not just public health, but think about with the examples that we showed of public health being related to the criminal justice system and other systems. All that to say, a solution to a public health problem may not be a public health solution. And we may need to look at other systems in order to resolve that problem. We also need to think about where those levers of power are located and think about those levers of power in context of the other systems that are happening, both kind of at the individual and community level, but then also thinking about things like our political system and the way that interacts with the mass media and local and state and federal governments, as well as just physical environmental risk. And then most importantly, we need to identify people who might be being sacrificed for other people's gains and make sure that we're bringing them and galvanizing them for action. What's neat about that is that might actually lead to bringing together groups that were formerly apart or thought that they were disparate, but actually might have something to gain by working together to dismantle something that's hurting all of them. So with that, I'll leave a couple of minutes to take questions, but thank you for your time today. Again, I hope that today's presentation has helped you reflect on the different things that you see unfolding in front of you in the media, but then also potentially in the work that you're doing in the regulatory space, and helped you and prompt you to think about the themes or the reasons that people are purporting the policies or the practices that they're purporting, so that you can be vigilant and thoughtful about how they are potentially hurting people to ensure that they can help people. Thank you.
Thank you, Dr. Dean. Thank you so much. So thorough. Thank you so much. If you have any questions, please, you all can, the chat is open. Any questions that you may have, place your questions in the chat. Thank you so much.
I'd also love to hear if this prompted people thinking about anything that's happening around them that might be being weaponized in some way. Other examples that you might have seen around you.
Sure. It's a really great question. I think there's a lot. I think since coming out of even COVID, I see a lot of systems, a lot of I think people, even our educational system, that are still I think reeling from COVID. The PTSD of COVID, not even just biologically, but just even our systems, our economic systems, just how we're still just coming out of that. Do you have any remarks about how we would learn lessons we can learn from that? Well, we do have a question here. Oh, two questions or two comments. Sure, was good to know. Obviously, the so-called MAHA movement is
Maha.
top of mind.
Yes.
Maha, okay.
Yes.
How do we re-evaluate wellness quackery and the trend of dismantle access through misinformation? Someone else mentioned I've learned recently about medical discrimination that is still being discovered today, but the Maha movement in particular.
Yeah. So the Make America Health Again, I think that is a
Mm,
great example, right? It's framed as health and protection. But when you look at the policies, those are not about health protection at all. And in fact, if you look, I mean, in some cases, they're pretty explicit about whose health they're interested in protecting and whose health they're not interested in protecting. There's also an emphasis on individual behaviors, but we know that individual behavior is framed in environmental contexts, right? I always say I use the example of a snowman or being in the snow. I mean, you can tell someone to keep warm, but if you don't realize and recognize that they're with a blizzard in a blizzard, how do you expect them to really keep warm even when you give them a coat? Right. So, yes, their individual behavior can try to help them keep warm. But if the environment around them is a blizzard, right, how do you actually expect them to actualize that? Or they can only go so far. Similarly, that's kind of my struggle with especially a lot of the MAHA policies, is they're so focused on individual behavior, but not about changing the context in which people can actually do healthy behaviors, or for which healthy behaviors, or to make the default context easy ways for people to be healthy. So that's a great point. The MAHA movement is a great point. And then someone said
oh,
they've learned about medical discrimination that is still being discovered today. Malika, did you want to say more about that? What sort of things you've learned about or heard about? I'm actually not sure if people can unmute.
hmm yeah, they can.
Oh, good. Calculations about lung capacity by that default involve race when it shouldn't. So there is a great example of that also with kidney function as well. There was what they were called kind of race-based algorithms. And whether or not you could get a kidney transplant was based
Mm,
on these algorithms that included race. The challenge is race is a social construct. Race is not biological. We've known that for a long time. And so people, for example, who were mixed race could easily get, by one definition of the algorithm, depending on how they were classified, be eligible or ineligible. And there's an example of a young man that actually happened to, that he was biracial, um, and his family, I think the doctors classified him as black in the algorithm, which meant that he wasn't actually eligible for a kidney transplant. But if he had been
mm,
classified as white by that same algorithm, he would have been eligible for a kidney transplant.
wow.
Right, this was just in the last couple of years. So, right, these things are
Mm,
still happening around us. All that to say, they've since removed the race component to that algorithm, but it sounds like, according to Malika, there might be some other areas where that's still happening.
wow. Yeah, there's a really great, I forget his name, TikToker who he's a medical student who's bringing light to a lot of these disparities within the medical field. Excuse me, different ratios and percentages and different embedded racialized and intolerances that are happening, calculations within the medical system that is bringing a lot of these different calculations to light. So it's been really interesting to see that happen. There's
Mhm.
another comment here. Black pain tolerance, pathology, and the
Mhm.
disparity of cesarean sections undergird the problems of medical education as curriculum and as a policy. What is the best practice for contemplating pro-social change in healthcare?
So I love that you brought up kind of medical curriculum. I mean, that's part of the reason I'm working in medical schools myself and doing this class, this power and privilege class, so that we can talk about these things explicitly. I do think that I think medical schools have been trying to change a lot of the work that they're doing around, for example, talking about racism and discrimination. But I think the challenge is that just gets at the medical students, right? And not necessarily the people who have been in practice and who have been practicing. So I would hope that there are things like continuing medical education or even in board recertification that would help to address some of these things. But agreed, I do think that part of the next generation hopefully will get a better education about it, but we still really need to be thinking about the people who are currently practicing. And I think we're at time. Just want to check my.
Yes, we are. Yes. Thank you all so much for your questions. Thank you all so much for being here. And most importantly, Dr. Dean, thank you so much for being here. And thank you for your most important work and chronicling these disparities within our health system. And, with the work that we do here at the PHRC and just the intersection of race and, of course, color, and just within the systems that we're working in and policy that you touched on today. Thank you so much for your commitment and being here today. So we greatly appreciate you. And again, for the work you do and your book. So thank you for making us aware also of the book that you have. Again,
Thank
thank you
you.
so much.
Thank you, everyone, for your time today, and thanks for having me.